Thank you.
Wow.
That should be a fast meeting.
That's good. Quorum?
Yes, we have 12.
This meeting to order at 4:02. And we're ready. So we're ready for roll call. You are.
Ms. Friedman,
I am here.
Mr. Arnold,
Here.
Ms. Banks. Here. Ms. Bell. Here. Mr. Brown.
Present.
Ms. Carter. Here. Mr. Janai.
Yeah, here.
Reverend Gordon.
Here.
Ms. Harding. Here. Ms. Howe. Ms. Mendoza Locke. Mr. Knowles.
Here.
Mr. O'Connor.
Here.
Ms. Rodriguez. Here. Dr. Russell.
Here.
Mr. Stengel.
Here.
Mr. Tiggs. And Major White. Thank you.
Thank you. Thank you. Welcome, everybody. It's so good to see everyone. I'm just really happy when I look around and I see everyone and we're able to do this in person. And welcome to everybody that's joining us via Zoom. The next thing on our agenda is to recognize our visitors. So let's start.
Amy Ross from the Act Force staff. Rachel Freeman's center.
Richard Arnold.
Okay, is that everybody? I couldn't
Yeah,
see.
there.
Okay, great. Well, welcome. Welcome. Trustees, I asked for you to, is there anything that needs to come off our consent agenda?
You need to say them by name.
Okay, we have the meeting minutes. We have the planning and oversight committee report, which would include the treasurer's report and financial statements, as well as recovery housing initiative and health officer designation. Okay, roll call, please.
Mr. Arnold.
Yes.
Ms. Banks. Yes. Ms. Bell.
Yes.
Mr. Brown.
Yes.
Ms. Carter.
Yes.
Mr. Janai.
Yes.
Reverend Gordon.
Yes.
Ms. Harding.
Yes.
Mr. Knowles.
Yes.
Mr. O'Connor.
Yes.
Ms. Rodriguez.
Yes.
Dr. Russell.
Yes.
Mr. Stengel.
Yes.
And, sorry, that's it.
You were on a roll there. Let's go. Okay, Scott, it's over to you.
Don't
You're-
blink, you might miss it, right? That might have been the fastest meeting we ever had. But I say that, but I want everyone to know, especially for folks that might be tuning in, these items were thoroughly discussed at the Planning and Oversight Committee meeting. So at that point, which the Planning and Oversight, as you know, encompasses all the trustees. So these items were discussed previously, so then they were put on the consent agenda and were not removed. I have a very brief director's report today because we want to get to our trainer today, Mr. Travis Atkinson, and I'll do a little brief intro of Travis as well prior to or after our adjournment. But as you all know, May 3rd is primary election day. We are moving forward with our planning for our campaign. Thank you to the trustees and volunteers that have served diligently on the levy committee. The levy committee has been meeting since early December, every other week, to plan the levy. And we are on course for another successful levy campaign. You'll see a bunch of signs that are sitting out there. Please feel free to take signs as you're walking out the door, and distribute them to your friends and neighbors, or whoever else you may want to, or whoever else may want to show their support. A couple of critical things that just kind of last minute stuff. We will have a flurry of activity over the next week and a half leading up to Election Day. It's 14 days away as of today. And we hope to be having a press conference here on April 30th that you'll all receive an invitation to.
28th.
28th, thank you.
Oh, I'm not going to be here.
28th. Thank you.
Ron, what time that is?
10:30.
10:30.
We'll send, so it's April 28th, 10:30
At the Warner Center.
at the Werner Center.
Please come out.
We will be doing a lot of social media. So please hit the like buttons and then share and get that moving to all your contacts. And of course, remember to vote. Not just yourself, but your loved ones, encouraging others. The turnout is expected to be rather low. I can't tell you exactly what that number might look like, but on an average primary, I think it's somewhere around 45,000 people that would vote. We need approximately half of that. So let's shoot for 20, 30,000. And in the first dump of election results come about 7:45, 8 o'clock. Let's try and be at about 70%. We know we'll be good from there. But again, I want to encourage everybody to do what you can to support the levy. And we are looking forward to a successful campaign. So Senna, I think you have something you'd want to say.
Yes, I was going to say, take a sign and then pass a sign. So if everybody could take just two, that would be really awesome. If you've already got them, it's cool. I know that, but that's just kind of like been my thing as I've been handing them to people is to pass it. And please, trustees, if you're available to come out the 28th, that would be great. We would love to have you there at the press conference. If you, as a trustee, have not contributed, please consider contributing to the levy campaign. 100% participation at this level is really important to the community, and we're not there yet. So I really would like it if everybody would participate. And, you know, I'll take 50 cents. It's not about the amount, it's about the 100% participation. And with that, we'll go on to open session.
I have a few other.
Oh, go
Let's
right ahead. Sorry.
No, I forgot what I was going to
Also,
say.
one thing that we did talk about today at the levy committee that we could throw out to the trustees are that Michael's going to kind of coordinate anyone who wants to do
perfect,
their own
Jim.
video that would like to do a 30-second video about why they support the levy. All you need to do is do it on your phone, email it to Michael. We're going to drop those on the Facebook site and on the website and incorporate those. So any of the board members who want to do that.
Great idea.
free to
Thank
do
you,
it.
Jim.
So,
Thank you. You could be a movie star.
Yeah.
Just saying.
So I just need to give you a few more updates on a few things that are going on. Election Day is May 3rd, as you know that. So we will not be having our regular planning and oversight committee meeting on that day. We are going to push the meeting in person May 10th. It'll be a joint planning and oversight executive committee meeting. So both committees will be there. That will start at our regular time of 4 p.m. The reason I'm making sure you're on the agenda, or make sure you understand it, it's off our regular time, but it's a very, very important meeting. You will receive the final contract for you to vote on so that we can get that out. You'll see the purchasing plan recommendations. You'll see first draft of the administrative budget. You will also hear any appeals from our 120-day notice that board staff can't negotiate and resolve prior to that. So it's a very important meeting. You should also prepare to be there perhaps a little longer than what you normally might be. If we do have a board-to-board appeal during that meeting, that could probably take at least a half hour. So you might plan, given all the other items on the agenda, you might plan to be here till 6 p.m. on that day.
Everything's here.
Everything is here, yes. And that's really all I wanted to say regarding just updates to what is exactly going on for the next month or so.
Thank you. Thank you, Scott. Yeah, and thanks for the reminder too.
Mhm.
That's for sure. All right. Do we have anything for open session? I count on it.
Just briefly, what's going on over at One Government Center last Wednesday, zoning and planning committee met. I think I've mentioned this before, there was to be a 4-bed facility for the mentally ill. Okay. Richard Arnold. The zoning and planning committee met last Wednesday. The facility at 353 Parker, this was to be a 4-bedroom facility for the mentally ill. No opposition of any kind. It passed 2 months ago at the Plan Commission, but last month was withdrawn. No reason was given. They just put it on the agenda so they could withdraw it, but it's been withdrawn. At the same meeting, Lutheran Social Services, which used to be funded by this board, has purchased a lot next to their building at Collingwood and Bancroft. I'm not sure what they're going to do with it, but they're going to put a pretty good sized facility there. They have run that by the Old West End Association, and they do agree that it would be a good facility. So that was passed with no problem. Last Thursday, Unison went before the Plan Commission for their 16-bed facility at 5044 Unison, or Dorr Street. It could have gone better. Former Councilman Larry Sykes was there. He spoke against it, and he was not bashful. There were talks about the shooting recently in New York and things like that. There were some people there from that neighborhood. Here's the problem. There are 2 unlicensed group homes in that vicinity that everybody has had a problem with. The daycare has had a problem with. The businesses have had a problem with. And Tom Gibbons, the chair, he's the president of, or he's the CEO of the Plan Commission, he wasn't bashful. He said, yeah, we've received a number of calls about them. There's nothing they can do. If it's unlicensed, there's nothing they can do. But the Unison people said, hey, we can't be held responsible for that. We will run this responsibly. At one point, and I've never really seen this before, they did mention this board. And they said, we've called the mental health board and we got no response. And that's all they said. The implication hanging over the meeting was that the mental health board doesn't care, which I know is not true because you did discuss this, I believe, a month ago. And this is supposed to be a 16-bed facility that has the capacity to serve both men and women. And they can be, well, they might have codes existing diagnosis, both substance abuse and mental health, but it really turned ugly. Well, the Plan Commission in a 4-1 vote approved it and the waivers because they are within 500 feet of another licensed group home. And it now goes to the May 18th City Council Zoning and Planning. I believe that is Reverend Hobbs' district. I'm not positive, but the City Council is quite divided right now. And quite honestly, some of them are just looking for something to go after. So we may hear a lot more discussion about this. Because the Plan Commission passed it, it will only require a simple majority of 7 votes and not the supermajority of 9 votes. But still, that could be an uphill battle. In my testimony, I said, hey, look at the connecting point. That closed in 2009, almost immediately was vandalized. probably going to sit there forever and attract drugs and criminal activity. Unison came in, bought that, and it's still functioning to this day. So yeah, I think we got our point across. And the Plan Commission members were visibly, they weren't happy about all of this. And they said, hey, we're not here to discuss, concerns about the mentally ill and dangers and all that, shootings and all that. But I would imagine City Council will be eager to have that kind of a discussion. We'll see what happens in May. When I read the editorial in the Blade on April the 10th about county jails and no place for the mentally ill, well, I just had to go back into my files. Brief bit of history. The county jail that we currently have opened in May of 1977, $12.1 million, state-of-the-art facility, and it had almost nothing for the mentally ill in it. The first of many problems was a man that was arrested for a rather violent sexual crime. He attempted to commit suicide, so jail staff sent him to the state hospital. He escaped the same day. He was wearing only pajamas. He walked right out the door. Nobody noticed. Nobody was notified. 4 days later, when Toledo police went to arrange a court date, he's not there. And there was some negative media attention. And 2 months after this state-of-the-art facility opened, a federal judge, I believe Judge Young, ordered that they make modifications for the mentally ill because they're going to be getting a lot more of it. And here we are, 45 years later, and there is still an ongoing dispute between our local Lucas County Jail and the state hospital, which I believe has only 114 beds today. And I know this board is working on a solution to that. How ironic, though, that it still goes on after all these years. And I want to ask the board to consider something that's very important to me. There is a piece of sculpture, which you can actually see from this window. This is called Seasons. It's set in front of the old community services building for 29 years. Brief history, donated by the Stranahan family in 1981. If you read the inscription at the bottom of it, it says it was donated on behalf of, let me get this straight, Robert Sr. and Frank Stranahan. It said it's donated to all the citizens of Toledo. And this sat proudly at the corner of Jackson and Summit for many years. And there's never been any building that housed more human service agencies. This board was in there for 25 years. A lot of the agencies this board funds were in there. It's a beautiful piece of sculpture. The sculptor is Larry Anderson. He's got sculptures all over this country. It's a grandfather and a granddaughter examining a fallen leaf. The inspiration is from the book of Ecclesiastes in the Old Testament, chapter 3, verse 1. To everything there is a season and a time to every purpose under heaven. It's a beautiful piece of sculpture. Well, United Way tore down that old building 12 years ago, and it's been sitting for 12 years amongst the 5-foot-tall weeds over there. I mean, nobody would see it. The weeds are so tall, you cannot see it from Summit or Superior. It faces an abandoned TARTA bus station facing Jackson. It's 50 feet away. And it is just so sad to see this great part of Toledo's history. The last, remnant of the old community services building. It's all that's really left. I go there on a regular basis to remember all the advocates that were affiliated with that building that are no longer with us. On December the 16th, Connie Sue Koch, she was the executive director of the Consumers Union, what's now the Werner Center. January the 24th, Bob Arquette used to be a member of this board. January 31st, Marcy Dvorak, former director of NAMI. February the 1st, Marge Shute, founding member of the Boost organization. February 17th, John Brandenburry, member of this board. And just yesterday, Mary Jane McCormick. She was chair of this board back in the 1980s when we downsized the state hospital, and a whole lot of people didn't like that. And I go there and I try to remember them, and with each passing year, it's just harder and harder for me to remember all the names and dates. So I want this board to consider possibly rescuing this abandoned piece of sculpture. I'm sure it's the loneliest in the city of Toledo. It's isolated, it's secluded, it's surrounded by weeds. It's very difficult finding out anything because United Way sold the building and property about almost a year ago. It's now owned by LMHA, even though the Toledo Arts Commission lists it in their media. I've been told it still belongs to LMHA. They have the final say. And if anything did happen to it, you probably need the Stranahan family's permission. But when we were at the Werner Center for the kickoff, I thought, oh, wouldn't this be great for the Werner Center? Because that's where the Werner Center was created, on the 5th floor.
And this month is their 30th anniversary. They were first funded, I believe, April 27th of 1992. And if you want to talk about changes, yeah, back then they were called the Nut House on the 5th floor. And we had to listen to jokes about the inmates running the asylum. But here they are 30 years to get, and they're still here. And I would just think it would be great if this sculpture could be somehow moved. I wouldn't ask this board to pay for it, but maybe the lobby for it. I'd like to see the Toledo Arts Commission move it. They've been known to do that with sculptures before. It's just establishing the ownership. I believe it's LMHA. Who knows what they plan to do with it? They might throw it in a warehouse for all eternity. It'll never see the light of day again. But it is such a beautiful piece of Toledo's history. I would love to see it moved to someplace better than where it currently sits, and almost nobody sees it. So I want to ask the board to consider rescuing the loneliest piece of sculpture in Toledo. It's called Seasons, and it sits way back from Jackson and Summit. So I thank you for considering that.
We would most definitely consider it.
Senate, thank you, Richard. You just brought back a whole bunch of memories for me. I was a young United Way staffer in that building when that statue was donated and put there. I was in that building when Tom Werner and Frank Ayers and all those guys were all in that building. And you're right, it is the loneliest sculpture. If this is something that the board is interested in pursuing, I would volunteer to work and lead the effort for that purpose.
Well, thank you.
I was there when that thing was dedicated.
Absolutely.
I was there when the decision was made of the Stranahans to fund it. And when the decision was made to put it there, that weekend, prior to that being done, a number of us helped kind of clean that area out so that they could come in and build a base for it and everything else. So, thank you, Richard. You brought back a whole bunch of memories for me. Over the last
Yeah, Jim, I wrote down to get a hold of Joaquin and find out to what we could do to maybe even keep it there, but bring more notoriety to it so it's not the loneliest sculpture and whatnot. But yeah, definitely. I'll be in touch with you and we'll get that meeting set up so we can find out what we can do with it. But thank you so much for bringing it to our attention.
I do want to make one other comment unrelated to that. The Unison Door Street project, if you recall, this board did prioritize that for our recent Ohio Moss Capital Planning Grant. When Unison petitioned the city of Toledo zoning and planning for a waiver, the ordinance that was changed caused the zoning and planning to contact us related to what our thoughts were regarding that project. I was very transparent with them. I provided them in writing via email that we consider that a mental health residential facility, not a substance use facility. The board is investing its support for that project via Ohio Moss Capital Grant. However, we feel that there would be a conflict of interest for us to say, should they or shouldn't they, because we have a dual relationship with them. So if Mr. Gibbons indicated that we did not respond, that would be inaccurate. So I will follow up with zoning and planning because that is actually the second time I've heard that statement related to us being contacted about this. So we will clarify that up, and I can assure you when we get a response or when we get a request, we do respond.
Thank you. I appreciate that reminder, that's for sure. Do we have anybody else has anything for open session? Okay, before we adjourn, again, what are we doing on May 3rd? And what are we voting for?
For our levy.
It's not a new tax, that's right. Okay, we're adjourned.
Okay, everybody. Let me introduce to you, go ahead. Travis Atkinson. Travis should be
We're gonna
well,
move, right?
yeah, we can go ahead and move. We're gonna put the PowerPoint on. You go ahead and
Oh,
do
okay.
that, because it's gonna take a while for it to come up. Travis is the consultant with TBD Solutions. That name should sound familiar to you all. He was instrumental in helping us facilitate the citizen or the Community Psychiatric Emergency Services Committee. He authored the report based off those committee meetings. He helped us develop the request for proposal related to the recommendations that were in the CPES report. And he is currently under contract with the board to support the implementation of crisis services at Zeph Center and the CPES recommendations that appeared in that report. Why do I bring the CPES report up? Because one of the many recommendations that were in this report was a consideration of purchasing crisis services in particular differently. Moving to a value-based purchasing process, or considering elements of value-based purchasing in the way we do our purchasing process. As a primer to moving in that direction, we asked Travis to come in and help educate this board and ourselves and the community on what we're actually talking about. Travis is doing a tremendous job working with Zeph Center, great communication with this board, and we have tremendous faith that Travis can really help move our community's psychiatric emergency services forward. Because of some of the work that he's doing here, and just because they do provide quality work, he's getting a lot of notoriety around the state, and other communities are now reaching out to TBD Solutions to do some similar work in other communities. So we're very blessed to have him as our consultant and really appreciate him making the trip to Toledo from Grand Rapids. And without any additional commentary, we'll just turn it over to Travis.
Thank you, Scott.
Welcome, Travis.
Good afternoon, everyone. It's great to see some familiar faces here. For those of you who were on the board a few years ago, I came here to kind of provide maybe I'll move over here a little bit. If we got the Slack, we have the Slack. What do we think? I think we do. I came over to your meeting a few years ago to deliver the recommendations that we provided in that CPES subcommittee report. What I've been very encouraged by in the time that we've been fortunate to work with the board is the board's commitment to making improvements in your crisis services. You may not know this, but not every state and not every county is as well developed in its crisis continuum as the board is here at Lucas County. So beginning with that crisis assessment, kind of taking a deep dive, or for those of you who are familiar with the 12-step model, a fearless moral inventory of what services you have available, and not just the adequacy or the existence of those services, but the quality of it as well. We were fortunate to work with your community partners, with law enforcement, with the hospitals, to really get a sense of what's working in your community, but also what could be improved on as well. Now, our company, TBD Solutions, has been fortunate to be in many of the national conversations around improving crisis services. So if any of you are, behavioral health or crisis nerds, so to speak, you're amongst good company today. We've been helpful in some of the national strategies, as well as in some of the seminal documents that have come out in the last 5 years pertaining to crisis services. And we always welcome the opportunity to take policy ideas and put them into practice. And so it's been a great experience for us, not just to deliver those recommendations, but to work with the board, to work with Zeph Center in enacting or bringing to life those recommendations. We're not going to spend a lot of time focusing on the CPES report today.
But it is available. It's out there. If you haven't seen it, I recommend that you check it out, because the board continues to be committed to the implementation of those recommendations. And that's kind of what we're charged with here in this contract as we work with Zeph Center to bring up to speed or into existence those crisis services that were being provided previously by Rescue. So today we're going to talk about this aspect of crisis services and behavioral health services in general. Yeah. Definitely. Yep. So for those of you watching at home, you can access the slides through the board's website. What was the break? Board information. Click on board information and you can find that CPES report. So we're going to talk about an aspect of crisis of my slides. Oh, that's great news. Okay. Good. Well, yeah, you can look ahead if you think I've spent too much time on one slide. Same thing, people in the room, just flip ahead. And there's a pile of them over here. So if you didn't pick one of those up, please feel free to do that, and you can kind of follow along. We care about everybody that's involved in the crisis continuum. We care about the payers, we care about the administrators, and we care about the providers. When we're all doing our job really well, especially in the public system, there is good accountability. We know that we're being good stewards of the funding that's available, and we know that subsequently that leads to good or quick and timely access to high quality services. How many of y'all in here have heard of the triple aim before? Just a few. Okay. The triple aim of healthcare. Okay. The triple aim of healthcare was kind of developed into this concept about 10 or 15 years ago, but it's this idea that good healthcare gives you high quality outcomes. Okay. So it has an impact on the symptom or the deficit that you're trying to address. That good healthcare has high client satisfaction. The person who's receiving care feels like they are, a part of it, that their input is appreciated, that they're treated well, and that it's done efficiently, in a cost-effective way. So we want to keep high clinical outcomes or high outcomes to treatment. We want to keep people satisfied with the treatment they're receiving, and we want to do that in a way that is cost-effective. That's the triple aim, and that's going to drive a little bit of our discussion today. Do you have your hand up? Okay. Your hand looks very comfortable in that pose then. Okay. And please feel free to raise your hand or ask questions as we're talking. I know how hard it can be to have a thought and then to, feel like you have to just hold on to that for a long period of time. So this is our agenda today. We want to talk a little bit about the vision of value-based purchasing. And I'm going to use a phrase that's similar, which might actually bring some more clarity to it. And that phrase is outcomes-based contracting. So we're going to use those terms interchangeably. And then we're going to talk about metrics a little bit and how what you measure in the system tells you about what you care about, or just the fact of measuring in general. Okay. I imagine many of you have, I'm not going to take that personally, Scott. This isn't like the 5-minute, right? Like lights on and off, like let's wrap it up here, guy. I imagine many of you have either looked at how much gas is in your car recently, looked at your bank account, looked at other ways that you're measuring kind of like vital signs of your life outside of your physical body to tell if things are good or not, or if you have to take action. Metrics in behavioral healthcare are no different. We measure what we care about. And so the people who are receiving care, especially receiving crisis care, should have an idea that the services you're providing them are working. Too often in behavioral health, we kind of leave it up to the mystery, to the magic, to the subjectivity of clinical interventions, when in fact, we need to be collecting data. We need to be collecting information so that the treatment that we're providing matches where the person's at. So that if you walk in, or if one of your family members walks in, you can have a high level of confidence that the intervention that they're providing is going to be helpful to you. And then we'll talk a little bit about next steps and what this calendar or this timeline looks like for implementing this concept of outcomes-based contracting into your contracts with your crisis provider. Do you mind opening that door there? We might just have a little bit of a connection issue There we go. Thank you so much. So let's talk about the vision a little bit. In crisis care, as I kind of mentioned around the triple aim, I'm going to add one piece to the triple aim. So we've got effectiveness, we've got satisfaction, we've got efficiency, and I also want to add access to that equation. We could have all of these services and they could be high quality and people could love them, and we could say, it's going to take about a week before we can address your crisis. None of these other ones matter if you don't have timely access. Okay, so when we think about a vision for good crisis care in Lucas County, what that means is that there's right-sized treatment. I like to call this Goldilocks treatment, okay? I don't want to go to the psychiatric hospital if all I need is to see a doctor, okay? And conversely, I don't want to go to urgent care if what I need is a psychiatric hospital. It's gotta be right-sized treatment. That's the sweet spot. That's when we know that services are being delivered in just the right amount, or as we call the scope, the frequency, and the duration. For anybody who has a clinical background in here, maybe you've heard those phrases before. But you know, what's the scope of practice or the treatment intervention? How often is that being provided? And for how long is that intervention? So a good crisis system is going to have timely access to care. It's going to be done efficiently, which means we're not overspending, you know, or we're not over-serving you when in fact you just need this amount of care. We keep satisfaction high, and we do that not just by polling the people who really enjoyed it, but by getting a high percentage of respondents in our satisfaction. And when I say satisfaction, I'm not talking about an annual survey maybe that the board does. I'm talking about every person that walks through the door has access to a satisfaction survey. And we ask questions like, would you recommend this service to a friend or family member? Were you highly satisfied? Okay, and we set benchmarks and we compare those to either other parts of the healthcare system here in Lucas County, or we compare them to national standards that other crisis organizations have been able to receive.
How often do people fill those out?
I can't speak specifically for your community, but I can tell you that there is not a lot of consistency nationally with publicly funded crisis services when it comes to administering a survey, let's say at discharge. And part of that, as we move into this outcomes-based contracting discussion, can be where you incentivize the provider to administer a certain percentage of surveys, and that is supported by a payment incentive. You could do that too.
Okay.
Yeah. Mm-hmm. Yep. But you know, in today's day and age, there should be so few barriers to access to provide feedback and satisfaction. And so by that I mean you shouldn't only rely on this piece of paper that they're going to fill out, but you should have a code that they can, you know, for any of you who have been to a restaurant recently, you know, you don't get a menu anymore. You got to scan this code on your table. Same thing for your satisfaction survey. You can get the feedback very quickly, and you use that to improve services, and it shows you that you value the experience of the person who's receiving the care. For too long, behavioral healthcare has built its systems around the doctors and anybody that works 9 to 5. That certainly doesn't work in crisis care. If you know anything about crisis care, you know that a lot of crises happen between 11 a.m. and 7 p.m. So that 5 to 7 p.m. window. When I worked in crisis services in a CSU, Fridays were a very popular day for extra crisis. You know, it was like a double dose of crisis. It wasn't convenient for my social life or for the wellness of my staff, but we have to have systems that are adapting to where the person is at and what those needs are. So good question. Thank you for asking that. So let's talk a little bit about outcomes-based contracting and the origin and what the different types of funding types are and what kind of incentives they might reinforce or encourage. So outcomes-based contracting is a type of reimbursement that rewards healthcare providers with incentives based on the quality of care they provide to patients. So what this does is it gives us a fundamental shift from paying for the existence of services to paying for the quality of those services. And it's something that has to be done very thoughtfully. It's not a decision that happens overnight. It's not something that happens without a lot of planning, but it helps to increase the assurance in that dynamic or that relationship between the payer and the provider that the services are working and that they're doing what you intend them to do.
And just a question, from an incentive standpoint, are we talking about cash?
We're talking about bonuses. We're talking about incentives. Sometimes we're talking about, and it depends on what collectively the payer and the provider decide together. But it could be a withhold as well. So, you get 95% of your contract. And then if you meet these compliance requirements, then you get the extra 5%. And if you measure in this way, then you get another 5%. Okay. So we identify what those levers are and what the appropriate points are to be reasonable with the provider to say, what can you reasonably control? But at the same time, how can we walk together to build this? And the nature of this relationship or of this effort requires a strong relationship between the payer and provider. Okay. We see in a lot of the communities that we work in a fairly adversarial relationship between payer and provider when it comes to crisis services. Sometimes payers can be very prescriptive and like to tell the provider what to do. Sometimes they can kind of create a scenario in which nothing is ever good enough. So these efforts have to be created within a dynamic where we're sitting on the same side of the table, not on opposite sides of the table. And we're saying, we want to try and solve problems. We want to be collaborative with our providers to say, how can we be the most helpful to the people in our community? How can we demonstrate with a high level of confidence that these services are working? So outcomes-based, yes. The organizations.
Because, like, I don't, as far as I know, I'm the one person on the board who's an actual provider.
Mhm.
And this system can tend to like set up a scenario where you have the organization pushing providers to do more, and they're not, and especially in public health,
Mhm.
they're not getting paid well.
Mhm.
And they're already overworked. And so are we increasing that? How are you going to manage that if the individual providers are not being incentivized?
Mhm.
And then at the same time, if you're like having here, they're going to call you, or here's a survey to fill out. If you don't give me 5 stars, you're going to hurt me. And I can't tell you how many times. And I've even been on the receiving end of situations like that. And they ask in the survey, did anyone tell you how to answer these questions?
Mm-hmm.
So then it's on me, like, well, I could, potentially cost this person their job,
Mhm.
because I don't know
Yeah.
what the repercussions of that are.
Yeah.
So, like, how do you build in processes to ensure that those things don't happen?
Great question. Thank you, Doctor. And we will get into some of the process that we're following. We're following a 4-stage model to get there, but you bring up some good points. We are bringing to the surface through this process the incentives and levers by which many of us are living by or around. Okay, and those incentives and levers have existed long before this discussion today, and we're becoming more cognizant of them, and we have to be aware. We have to be aware of misreporting or slanting that reporting to say, if you don't give us a 5, we consider this a failure or something like that. I have this argument with my wife sometimes about like an Uber or a Lyft ride. I'm like, it was a good ride. I don't know. There wasn't any mints in the back seat or anything. So I don't really want to give them a 5. And she's like, well, just give everyone a 5. I'm like, well, then that diminishes the 5. If everyone's special, no one is, right? And so we have to set, whether it's some firewalls or some guidelines in the process so that we want the accurate information. We don't want just good news. I don't want a 20% return rate on my satisfaction surveys, but that 20% says we give you all 5s. Okay, that's such a small sample size. I want to hear from everyone. I want to hear from the disgruntled person. I want to hear from the happy person. The first comment you said, asking providers to do more with less, certainly. acknowledge that could be a concern. We want to ask providers to do things differently in some ways, not just to do more. You may be already delivering these services. You may already have the electronic medical record to collect some of these outcomes. We just want to start to report on it. We want to make sure that the clinicians are using that part of the electronic medical record at a high frequency, and that we're getting a report that is decided collaboratively on what, we talk to the provider and say, what do you want to be measured on, or what would be the most helpful measure of these 4 or 5? And then that allows us to go through that iterative process to say, okay, we're getting ahead of ourselves a little bit. This will make a little bit more sense hopefully shortly, but it's deliberate, it's intentional, and it's not intended to make the provider's life more difficult. It's intended to bring more accountability to the process.
And I want to clarify, I was more speaking about the impact of implementing the system on the organizations that we fund. Because it's not that we would be creating more work for the providers, but that the organizations may, in an effort to increase their funding.
Oh, I get it. So it's not us.
It's not us. It's like we're saying, like, this is an important thing to do.
Yep.
And it is important to make sure that your services are quality and people have access and all that stuff. So I like the idea. It's like, how do we implement it in a way where we're not inadvertently punishing the actual providers, the individual people, the clinicians who are already overworked, they're underpaid, and it's really difficult work. It takes a huge toll on people, and lots of people leave the field because of that.
Yeah.
And
Great.
then we're going to be in even more trouble because then we're going to not have the providers to serve.
Yep. It's great questions. We're gonna get to some more of those details, but thank you for bringing those up, Doctor. So outcomes-based care models revolve around the patient or the client's treatment and how well a coordinated care team can improve those outcomes based on certain metrics. So things like reducing hospital readmissions, improving preventative care, and using particular kinds of certified health technology. Those are a couple examples of ways that we might bring outcomes-based contracting into fruition. So I'll give you a couple examples of payment categories, ways that communities pay for services. So it depends on the state. Sometimes it depends on the county, which one of these you see. So the first one is fee for service. We see a lot of communities where the behavioral health crisis providers are paid in a fee for service way. So it's very traditional, it's transactional. You provide a service and we pay you for it, okay? What does that incentivize the provider to do?
See as many patients as they can.
Exactly. If I'm running a psychiatric hospital and we only get paid when people come through our doors, then if we're not disincentivized or penalized for a person coming right back, then we might be okay with keeping our beds full from people who come back more than once. But we know that that's not good for the person being served, right? We want that psychiatric hospital experience to be high quality and to last, because it's an expensive service, and preferably people go into the psych hospital as infrequently as they, as frequently as they absolutely have to, that it's not a revolving door. And fee for service can sometimes inadvertently incentivize a revolving door. So in fee for service, payments are not tied to quality. Okay, it doesn't matter about the quality of the service. Yeah, maybe you have a licensing audit or some kind of audit you have to do here and there, but provide the service, you prove that you provided it, we give you money. So, like you said, the providers sometimes are incentivized to overserve somebody or to overserve a community. Oh gosh, clicker is just a little bit. Okay, there we go. Okay, so in the middle, we have a capitated rate plus a fee for service. Has anyone heard the phrase capitated before? Okay, so capitated means you get this amount of money and it's your job to manage the population with that amount of money, okay? So if you keep psych hospitalizations down, you're gonna get to keep more of the money. If you keep expensive services lower, you're gonna keep more of the money. And so providers in this instance are paid regardless, again, of quality. Providers actually might be incentivized to underserve in this arrangement because they're already getting paid. So why should I provide 4 counseling visits when I can provide 2? You know, I'm not being held accountable for the outcomes, and I might get to save all that money that I'd be spending. And it requires strong quality measures in order to do it right, both with process and with outcomes. And I'm going to come back to this column here in a second. Population-based providers are incentivized to optimize the population health. So this example, capitated plus fee for service. What this means is, and this, as I understand it, this is how the payment arrangement currently is with Zeph Center. Okay, you have a monthly amount of money that is being given to Zeph Center to operate crisis services. Then they're able to bill some of those services, like kind of like a la carte, to Medicaid, and so they can make a little bit more money if they are billing appropriately for those services. And we've surveyed a number of the other CSU operators in the state, and they say the same thing. They say, yes, we get paid by our board, and we can also increase or improve our revenue, our bottom line, by doing some billing for these services. But when you're in population-based, and there's no additional fee for service, then you're incentivized to optimize the population health. Basically, what that means is you want people to stay healthy, to stay in low-cost services. You know, if a peer support visiting once a week is going to help keep someone out of the hospital, and you know the daily rate of a hospital, you compare those things and you say, we should stick to community-based incentives. You know, that should be what we go for first, instead of sending people up to the highest and most expensive level of care. And a capitation payment has kind of a comprehensive population-based payment. What that means is a lot of factors can go into paying somebody to cover a lot of different lives. Yeah, Scott.
I just want to provide just a little point of clarification related to capitated and fee for service as it regards to Zeph. Yes, we do provide a capitated amount. Yes, they are able to bill fee for service, but third-party providers in particular. But we ask them at the onset how much it's going to cost them to provide these services and how much of that will be third-party payer sources. So they're not double billing for a service.
Right.
Just want to make sure we're clear.
Thank you for
I appreciate that.
Thank you for clearing that up. I want to bring this into kind of a real life example. So this is a car wash right by my house. It's called Tommy's Express. And Tommy's has an option where you can pay by the month. You heard, maybe some of you have this before. Yeah, okay. I don't have to pay every time. I want to be able to go there whenever I want to. And I want to, you know, I'd rather pay a monthly rate and know I can go as many times as you want instead of having to pay every time. So in the car wash example, if we're talking about a fee for service arrangement, that's actually how I go about washing my car. Okay, I pay every time I go. There's no limit to how much the car wash can make in this scenario. Okay, as long as you got people coming through, they don't care if it rains in the afternoon when I got my car washed in the morning, right? They're praying for rain a little bit, you know, because then I might have to use them again. So there's no limit, and they benefit when I consistently get my car dirty. So they want to, you know, just see people and see people and see people. Now, for those of you who are, let's get all three of them up here. We'll go down here to population-based. Car wash, if the car wash was responsible for the cleanliness of all cars in the zip code that they operated in, how would they operate differently? If they made, you know, $10,000 a month, and instead you said, we'll give you $11,000 a month, but you have to give people car washes all the time, what might they do? They might come up with an invention that puts like an umbrella over your car so it doesn't get so dirty. So they're going to see you a little bit less. You know, they don't want to see you. The more times they see you, the more their profit is being driven down, right? The more their income. So they want to creatively keep people's cars clean with that low cost. And so then in the middle here, we've got the capitated plus the fee for service. Car wash is given a large sum of money to wash a car of any person in the zip code. And then they can also earn additional money through selling air fresheners or vacuums or, you know, little add-ons, things like that. All right. So this kind of gives an idea of how the car wash is incentivized based on how they're getting paid. Okay. So I want to walk you through these phases
of implementing this value-based payment or this outcomes-based contracting that we're talking about in our work with Zeph. There's 4 phases. The first is pay for participation. The second is pay for reporting. The third is pay for performing. And the fourth is paying, for success. Okay, so our goals in the pay for participation phase. This, by the way, is the phase that we are in right now with Zeph Center. We just started this initiative about a month or 2 ago, and we are walking through this phase. The goals are to gain agreement on the priorities and to define value. So we've had meetings with the board, we've had meetings with Zeph Center, and we've had meetings together. And one of the questions that we're just trying to explore in these meetings is, how do we define value in crisis services? What would you say if you had to define value? What would be an example of value in mental health crisis services?
It'd be a value that was derived by the patient.
Okay, the patient would make that decision.
The patient would make a decision in terms of whether or not they were helped for the particular ailment they came in to be seen for.
Okay, great, good. Another way? What's another way we would define value in crisis services? Yeah, you do it, your services are effective the first time. Yeah, and so maybe we could call that a readmission rate. We could say at 7 days after they left the CSU, only 10% of the people came back,
But that would be great, but who decides whether or not they're services?
Who decides whether that's a value?
For example, if you have less persons coming, is that a decision made by the individual, or is it built in the system that prevents them from coming to service?
Yeah, that was my.
Right.
That's a great question. So I'm going to bring up Reverend Gordon. I'm going to bring up an example that is a little bit more complex, but speaks to that challenge. Okay, most communities that we work with, the hospitals, we work with communities that have multiple hospital systems, 2, 3 psychiatric hospitals sometimes. We can say, okay, what's your readmission rate from your hospital back to your hospital? And they're like, that's easy, we can tell you that. We say, okay, what's your readmission rate from your hospital to that hospital? And they say, we don't know. But what's your readmission rate from that hospital to the CSU? Well, we don't know that either. Oh, so they will say they can only control the readmission rate back to their own program, but the community cares that that person's going to any expensive service
Exactly,
after that, right?
right, exactly.
But that's because, if a patient goes to crisis services, does not get what they need, and they're forced to go to another facility,
Mhm.
right?
Yeah.
That,
Yeah.
But that the original place that the patient went to, so I was gonna say something towards like the electronic patient records
Mhm.
would help with that. And coming out of crisis is the continuum of care. Like, is this person really going, feel motivated to go to that next level so they're not back at crisis? And that continuum of care, who's helping this person go and go to doctors, whatever they need, peer groups,
Yeah.
medication.
yeah.
Mhm.
It's, that's where the value is.
So back to your question, Reverend Gordon, how is that determination made? It's part of this collaborative process that happens between the payer and the provider, but it's also informed by best practices nationally. And what we see are benchmarks that have been established in communities that have been measuring this for a while, where they say, let's we're going to talk about readmission rate in a second, but we say, okay, we'll talk about satisfaction. Okay, we want 90% of the people to complete the survey, and we want 80% of them to say they have a positive experience. So let's try that out. And we collect the surveys, and we get 75% completion, and we get 65% satisfaction. We say, well, maybe our benchmarks are off, so we got to talk about if we're going to set those differently, especially if there's going to be a payment incentive tied into that. And so it's a collaborative process that's informed by by data, by evidence in other communities. We might look at other places in Ohio that are collecting data on the CSUs and say, how well do you collect your satisfaction scores, and what kind of satisfaction scores do you get? And then we use that to inform where we're going to set the benchmark. And it's a collaborative discussion, but it's based on a mutual understanding that we have to have some examples of quality. We have to use measurements to inform whether this is a quality service or not. Okay, a couple other things on pay for participation. In this phase, you're paying the providers actively to participate in these payment reform meetings and planning and readiness activities. That might sound kind of weird. Say, gosh, you're going to pay them to show up to a meeting? Yeah, payment is an incentive. It's a form of incentive, and it's what we're going to use throughout these 4 stages to drive behavior, to drive improvement. So what we're doing in this phase right now is to identify the metrics and outcomes that we should use to measure, and also how that data should be reported. Is this going to be in a spreadsheet? Is it going to be some kind of output from the electronic medical record? Who from the board is going to collect that? Those are all questions that we're talking through, and we give ourselves quite a bit of time. I'll show you the timeline, but we're talking about 4 to 6 months for each of these phases, and they involve collaborative discussions with different like department members of the board and of the provider as well.
Are you including the actual providers in those discussions, or is it only the upper level people?
We're including the provider. So if we're having a finance discussion, we're asking somebody from the finance department, the CFO, or one of the I'm going to show my ignorance of who else works in the finance department. Someone from the finance department is going to participate from Zeph and from the board.
I'm sorry, I meant clinicians.
Yeah, for the clinical discussions about, hey,
For the metrics and outcomes.
yep, hey, we want to measure client a pre-test. Tell us your depression scale, 0 to 10 at admission. Tell us what it is at discharge. So we're going to have clinical directors, clinicians that work in the programs to say, how hard is this going to be to measure? What would it take to measure it? And how long is that going to take to implement? Yeah, this is, I don't know. For those of you that have, you or your neighbor or a family member has like a green egg, like one of these slow cooker kind of situations, we all get old enough and then we start waking up in the middle of the morning to turn our meat over. Like, that is a slow process, okay? You really cared about that rack of ribs if you spent 17 hours of attention, putting it on there. It's the same thing with these discussions, y'all. We are not interested in a drive-by, fast-paced discussion that just says, let's do this as fast as we can. It's process-oriented. It's changing how we've always done things in the interest of the people in your community that are being served. Wouldn't you like these processes to be happening behind the scenes? If you've ever had a heart surgery, if you've ever, taken a family member to the ER, you yourself have had some kind of condition, don't you want to know that there's a level of thought behind it, that quality is ensured, and sometimes the providers that are demonstrating that are being compensated appropriately because they're delivering good care. They're not just delivering care. So we're also assessing the readiness. I kind of mentioned this, Dr. Russell, with value-based care. We're saying, if you don't feel ready to do this, what would it take to get there? Do we need to look at some more examples of what other communities have done? Do we need to do a beta test or do a pilot, to try this out without worrying about it? That's kind of what this is in some ways. We're just asking you to participate. We're asking you to show up to the meetings, engage in discussions, and there's already an incentive that's involved. So the next phase of this is pay for reporting. We want to pay people to report the data. At this point in phase 2, we are not making a value judgment on whether the data is good or bad. We're looking at, has it been submitted? Okay, how much of this data did we get, and did we get it in a timely fashion? That's kind of most of what we care about in this arrangement. So however the board decides that they want to collect this data and they want to analyze it, It may go into something called a reporting data warehouse. And then you're also going to decide, how transparent is this data going to be? Are you going to have a dashboard on the board's website that says, here's how we know our crisis services are working, or here's what's happening? Would you mind bringing that keyboard over?
That's what I was just.
Oh, thank you, Scott. Yeah,
I'm not sure.
that's going to be our backup plan here.
Yeah, I'm gonna put just,
Thank you.
is that right?
So if you want to bring it right up here, actually, then I can.
I'm not, I think you're gonna have the same problem.
Same problem, okay. So the payments are supporting implementation and the use of the health information technology. So I know Zeph Center has an EMR. I was there earlier this afternoon talking to some of their staff about how it's going, with documentation, with, different efforts. And maybe to run a new report, it's gonna take a little bit of work. It's gonna take some trial and error. That's part of what this phase is for. I'll get just a second, I'll get right to you. So you incentivize the reporting. Let's say you say 80% of the metrics we want to know are being reported on. We don't care yet about what the data means. We just want it to be reported on a per month basis. And then we're asking again for participation in these payment reform meetings. Continued discussion to say, how is this going? What can we shift? What can we adjust as we get ready for the next phase? Now, please know, I alluded to this a little bit earlier, but please know that this is not an all or nothing arrangement. Okay, we're trying to find the reasonable sweet spot, if you will, to incentivize behavior, but it's not, if you don't report, you don't get paid. We're talking about somewhere in the low to mid 90s we see in most communities. That's the structure we're talking about. And sometimes, actually in a lot of cases, you keep only this as an incentive for a period of time before you start talking about a withhold and an incentive that's being involved. All right, so to your point, we've got a strained behavioral health workforce. We don't want to add additional like stressors or issues. When we do this deliberately, and then we say, hey, you could make 5% more than what you're making right now by doing this reporting, that might allow you to bring on additional staff to do this kind of reporting, or to to see these things to fruition.
What's this EMR?
EMR, electronic medical record.
Okay, just
Yep.
want to make sure. I thought that's what it was, but the way.
Thank you.
So I have a question.
Yeah.
So I assume that there are safeguards that would be put in place to keep the data from being manipulated more favorably maybe than, not saying they would do that, but obviously just making sure that we're really getting a true reflection of what's going on.
Yes, there'd be safeguards in place. That would be a discussion. Again, back to incentives. It doesn't matter what happens in theory at a planning meeting. It matters what happens in practice when you're on the floor in second shift and a person's discharging against medical advice, and your frontline staff is thinking to themselves, should I have this person fill out a report? They seem pretty upset. Should I have them fill out a satisfaction survey? They seem pretty upset right now. Well, if your payment, your incentive model says you get, the incentive is just as important on participation as it is on the results, then that's going to inform behavior. But yes, you set safeguards in place. You talk about, how can we mitigate that and make sure that that's happening as little as possible. But I'm here to tell y'all, if the worry about that, the alternative is not just to not ask people to report anything because you're worried that they're going to misrepresent the truth if we ask them to. Okay, both are bad, but if we're just not asking the question and we're not trying to measure quality because we're worried that people are going to do something nefarious, what does that say about our beliefs in the people that we're working with? Okay, I don't know. I've only been working in Lucas County for a couple of years, but are we assuming positive intent in the system? And do we have high levels of trust in these relationships?
Question. I see people reporting, and I see payment for reporting. I mean, obviously, I would build that into terms and conditions before as part of giving you a contract or giving that entity or someone a contract.
Yep.
That will be a part of a standard package, payment package. In order to do that, you must do this. So are we talking about in addition to, I mean, add-ons or?
We're talking about language that would make its way into future contracts. Okay, so I'm sure some of you are familiar with how the board contracts with its current provider network, and there are some expectations in place of things that need to be reported. Quick primer on measures. Okay, there's 3 types of measures. There are structure measures. Okay, how many people did you serve? Okay, how many how many mobile crisis outreach visits did you do? That's a structure measure. You're just measuring a thing, okay? Then there's process measures, okay? How many times or in what percentage of people did you check their blood pressure? How many people did you give a satisfaction survey to? Did you do a thing? That's a process measure. And then the third is outcome measure. Did the thing that you did make a difference? Did it improve a life? Did it decrease depression? Did it improve hopefulness? Okay, structure, process, and outcomes. What do you think is the easiest one to measure? It's structure, right? You just got to count. It's a Sesame Street exercise, right? One, right? You just got to count something, okay? Structure, process. Okay, it's getting a little harder. We got to know, did we do what we were supposed to do? And then outcomes. Oh my gosh, did what I do actually make a difference? As you move along, outcomes measures carry the most weight, but they can sometimes be the hardest to collect. But that's what we're going for here. So I have seen structure measures and some process measures in the contracts that I've been privy to. We're trying to move towards some more outcomes measures in a fair and just and palatable way.
Well, with that being said, then funding would be an issue because allocation. If we are allocating X amount of dollars to an entity perform those services and they're standard reporting things of that sort, so should an entity hold back funds? And because how are you going to fund that? What funds? If you're giving all your money out in the beginning when you're letting that contract or negotiating that contract, and where's the funds? How are you going to pay for the incentive package?
Good question. So one of the challenges we have, every community has its challenges with how the payments are set up, right? My understanding is that the board does not pay for psychiatric inpatient hospitalization. Is that true? That's true. That the Medicaid health plans in Ohio pay for psychiatric hospitalization. The board is paying for the crisis continuum, okay? If you do this well, and one of your measures is, we don't want people to go to the hospital that were just at the CSU, and you achieve that measure, and you keep a lot of people out of the hospital, you're now saving not the board a lot of money, you're saving the Medicaid health plans money, okay? That's called an ROI, a return on investment. You say, we invested in this crisis service, it diverted people from the ER or from the psych hospital. So then, the next logical step in that process is to go to the Medicaid health plan that you just saved $2 million. You say, to keep these services sustainable, it costs about $250,000 just to serve, the people that are your members. So it becomes a larger conversation when you can start to demonstrate that your publicly funded crisis services are saving many other parts of the community money. Okay, we've worked in Kent County in Michigan, and we're able to get data to say, here's how much a jail stay costs. I'm sure some of you know that data here. Here's how much a jail stay costs. If emergency services can divert a jail stay, and they do that 10 times a month, then who are they saving money for, and how can we turn that back into continued sustainability of the services? Okay.
Could you take the example you gave of Medicaid to the next step?
Yep.
So what?
Okay.
So they're going to say, "Oh, thank you for doing that." Walk away.
No. Yep.
What's
Yep.
the next step?
And in the interest of good relationship, we're going to say, look, we saved you $2 million. In order for this program to be sustainable, we have to reinvest into this, and it's not. And we hope we can demonstrate the value we're providing to you. And here's how we can continue to do this. The psych hospital is, in most communities, the most expensive thing. And so health plans are always trying to keep that cost down. And if you can do that through your CSU, emergency services, mobile crisis, then you're kind of bringing a value proposition to them and saying, here's a better way to do it. We see not just Medicaid health plans, we also see commercial health plans that invest in these good ideas. And you're asking for 10% sometimes of the savings that you actualize for them, but good data makes that case. Okay, I can't just walk into a Medicaid health plan's office and be like, well, I think we saved you millions. So, it's part of that sustainability discussion, but we have no way of knowing right now how well the system is working because we don't have these types of measures in place yet.
Right, but CMS isn't actively going out and asking all of the funding agencies, hey, we want outcomes data, or we want outcome data, and to see if we can lower our
Not right now, they're not.
expense.
But what I tell providers, the best time to measure something is when you don't absolutely have to. When you're not under the gun and suddenly it becomes an unfunded mandate, as we say. We want to be proactive about this.
What does CMS stand for?
Center for Medicaid and Medicare Services.
So the third phase, y'all have great questions, by the way. This is really fun. And you're probably also hungry too, so I'm going to keep this moving. Pay for performance is our third phase. The goal is to pay for achieving the process targets. Okay, so that's a little bit different than the outcomes targets. So if we want the nurse in the CSU to measure the blood pressure of somebody 100% of the time within the first 3 hours, then how close did we get to that 100% number? That's a process measure. Okay, if we lower their blood pressure, that'd be an outcomes measure, but we're talking about a process measure. So, yeah, this is good when I write the slide and then I say it and I look and I say, oh, I already said that. Okay, pay for complying with and implementing new procedures. So we're kind of tweaking things here. So each of these taking 4 to 6 months now. This is phase 3. So we're about a year into this process before we get to pay for performance. The provider performs the incentivized activity. We see an increased use of outreach, peer support, engagement, care coordination, anything that's keeping people in the community. Okay, any like follow-up care, anything that's proactive to keep people out of high-cost services. And then the last, we incentivize the providers to invest in the delivery system improvements that reduce health disparities. So this is where we can start to say, gosh, we know that in this community, we're serving a lot of people and they're having these comorbid conditions, or they're also struggling with homelessness, or they're struggling with these other areas. And so then we can start to engage the conversation to say, what else can we do to be helpful now that we've collected so much of this data? Okay, and our fourth stage is paying for successful outcomes. Our goal is to pay for achieving the outcomes. We're paying for the care that is working. This is when we finally start to know after, now by the time this whole process is done, we're talking 18 to 24 months, we can have a good idea that it's working, that the crisis services are doing what they intended to do. Remember the triple aim? Reduce cost, keep high client satisfaction, and high clinical outcomes. If I came in with severe depression, was my depression lower when I left? If I came in suicidal, am I having less intrusive and frequent suicidal thoughts? And good crisis services, I was just talking to one in Houston today, good crisis services don't just care about taking the bad things away from a person's mental distress, or let's say depression. They also care about the good things. What are you doing to add value to this person's life? How are you helping them to get reconnected with family, or to take steps to make sure that they don't have to come back? It's not just about not being suicidal anymore. It's actually about sitting in this space and thinking, how can we be the most helpful? How can we truly care for this person who's in crisis? And payment for improving your baseline or hitting the benchmark. So in the interest of this being a collaborative discussion, everything doesn't stay the way it is forever. That it's iterative, and when you have good quality teams that are working together, then the measure that you use in 2023 might not be exactly the same as the one you use in 2024. Maybe you've shown it to be so good that you're, as the provider, if you're Zeph, you're ready to tackle something different. You're saying, we're doing that really well. We can keep that as a measure, but let's change it a little bit. Let's see what else we could do to help these people that we're serving. Quick example, 30-day readmission. Okay, this is a measure that health plans care about for psychiatric hospitals. We see a lot of CSUs that do the same thing. 30-day readmission says, you know, when you discharge, what percentage of people came back within 30 days? It's an indicator to tell if they got the care they needed at the time and if they were connected with aftercare in the 7 or 30 days following. Pay for participation. Participate in meetings to define readmission parameters. What do we mean by readmission? If a person leaves AMA and then they come back, do we count that one? You get kind of down into the weeds in that process. Pay for reporting. The provider reports readmission rates according to agreed upon parameters. So what are we going to consider to be a readmission? If somebody comes from the psych hospital within 30 days and they go to CSU, should we really be, you know, held accountable for that? The third phase, pay for performing. Provider reports readmission rates for 95% or more of clients. Now, this doesn't mean that they have to, this is, again, that process measure, not the outcomes measure. So we're paying to know 95% of the results. And then in pay for outcomes, they achieve those 30-day readmission rates, let's say at 10% or less. So we want to know that our CSU is good and effective so that less than 10% of the people are going to come back here within 30 days. Okay?
And you guys, I mean, readmission is the biggest problem. Is that what you've identified in your investigation?
It's different for every community,
Okay.
but we see this as a primary measurement in most communities, readmission rates.
Okay.
They'll have a 7-day readmission rate and a 30-day readmission rate. So there's an organization called HEDIS, and those two measures are actually a HEDIS measure that a health plan is maintained and judged on for their members. Okay, a little bit of metrics. If you can just click this, and so they kind of all come up. These are some examples of metrics that demonstrate the vision, okay, that demonstrate the values of your organization or of your community. So timely access to care, there's a couple measures here, like how long does it take from the time you come in until you see a psychiatrist? And how long do we want that to be? Customer service, we've talked about that one. Percentages of discharge with a follow-up appointment scheduled, that should be an expectation. You should know where they're gonna go next. The time at which a person is most suicidal, if they came into the psychiatric hospital with suicidal thoughts, is within the first 2 to 3 days after they discharge. So you don't want to schedule an appointment 3 weeks out for that person. You want to have a peer support meeting with them the next day, or getting them into a next day appointment with a therapist. So,
I see you reporting a percentage of reporting a positive experience. I know just from doing customer surveys in my past life, you're going to get a lot of people who will take out their anger in a survey. But there was something real that caused that anger. So you don't want an incentive that's in place that discourages our partner from reporting the not so good surveys.
Mhm.
Because it's important to hear from them, and people are more likely to fill out a survey when they haven't gotten good service than when they have.
yeah,
But if you ask really specific questions, you can kind of throw out the ones that you believe that were filled out negatively because of anger or something like
When
that.
I'm looking at data, if I don't see some negative scores, I'm not gonna believe the
Yes.
results at all.
Mhm.
Right, that means the questions are too easy or.
And I'm also looking at not just how the questions were asked, but like, what is the way that the information is collected in terms of the score? Like, if you're using like 1, 2, 3, 4, 5, then you automatically get people to say 5.
Yeah.
But if you use just like a sliding scale where
Mhm.
there's just 2 end anchors, then you can get a lot of variety and catch a lot of nuance that's not there.
Yep.
So, I mean, I agree, and this is a really complex problem.
It is.
Yeah.
Yeah, I mean, you want the ones, you want to hear from the angry ones, because they're gonna give you insight to how to be more successful.
Yes.
That's where the gifts are. You know, this needs to fit this, we never even thought about that.
Mhm.
See, then my question goes to this is all about the service being provided to the people they're receiving service, they're graduating. I can go to school and be in school and sit next to Lisa and study with Lisa and get good scores with Lisa. But what happens when I walk out? It's when I walk out. It's what happens that part of that part of aftercare. I think that's where the biggest measurement needs to take place. So how would we put that into place, allowing us to look at the service providers and say, okay, what is the expectation of this person doing 90 days in here, having a good, successful outcome, but then 2 weeks later, they're back at this place over here, restarting the same treatment set all over again, and we're seeing that repeat. So how do we measure that?
Yeah.
So you're saying bad support, aftercare support, right?
Yeah.
Okay.
Fortunately, with an organization like Zeph Center, crisis services is just one more of a bevy of services that they provide. And so I think the advantage there is that they have access to outpatient therapists and peer supports who can do that follow-up very quickly afterwards. They can do that wraparound. So when I worked in crisis stabilization units, my concern, even though our agency offered a lot of different services, was I have no idea how well this person's doing after they leave. I'm kind of hoping that they do well. You know, I then have to care about the person who has replaced that person in the CSU. But where our behavioral health care is actually moving is towards better care coordination and follow-up after a visit. So if you've heard of Zero Suicide is an initiative came out of Henry Ford Hospital System, and it emphasizes the importance of wrapping around or of follow-up care after a critical visit. So I agree with you completely. What that allows you to do when there's funding that's in place that the crisis provider can also be the person to follow up, then they can know if they're achieving that mission or that vision of good crisis care. So maybe the best way isn't to wait for them to show up and then measure that. Maybe the best way to do it is to, what we see, there's a program in Columbus that does this, follow up the next day, follow up within 72 hours, follow up within 7 days.
Yeah.
All three of those things, okay? If we really care about the person we're serving and we have the resources to pay that person to do that follow-up care, then that's a great opportunity. Oh, you didn't get connected with that provider, we gave you their phone number, you know, the phone stopped working for them. Let's get you connected with a different outpatient therapist, you know, or let's get you a different intake appointment. We're all trying to answer the question in crisis services of how can we be the most helpful. Those are tangible ways that the crisis provider can be helpful and assure that their service, that the progress that was made while that person was in treatment is not lost. So good questions. I want to go to the next slide. So here's the next steps. Here's the calendar that we're kind of working within. In March, we started these conversations, and pay for participation goes through August of 2022. Then we go into pay for reporting, which will take us into February 2023. I don't have the next two slides up there, but those would be the other phases that we talked about. So to actualize this, it's a slow cooker approach. It is, let's be deliberate. Let's not rush this and say, oh, we got to do this really quickly and disrupt everything. Let's have intentional conversations that are mutually beneficial, where people feel understood, they feel heard. And you know what? In a very short period of time here, Zeph is gaining expertise as a crisis provider. And so they have insightful things to say about what could be measured and how they believe they can be helpful. I'm very encouraged by Zeph. They've been motivated from the beginning to be helpful, to fill this need. And we found them to be a great partner in these conversations as well. They've been very receptive in early meetings to saying, you know, they actually have had some experience or some exposure to this work before. And, I don't have a slide about this, but when this goes well, not if it goes well, but when this goes well, and you have a higher level of assurance as a board or as a board of trustees that the services that you fund are working, it will probably get a little bit contagious to say, I would like to know with even more certainty with the other services that exist where this is going. And this is not a new idea, y'all. Outcomes-based contracting has been around for at least 20 years. And sometimes you see it in the SUD world, sometimes you see it in outpatient. But it's all comes back to wanting to know that the services are doing what they're designed to do and what they're intended to do. And if they're not, it's a collaborative effort towards doing that. It's not a, it doesn't, it's not fraught with tension and with, and frustration. It's collaborative to say, let's make these services better. So as I mentioned, those are the phases, and I'm happy to take any other questions or hear any other reflections about what we've been talking about.
I had a question.
Yeah.
So from the lens, from Zeph's, from their lens, what's their biggest concern about doing this? Have they voiced that, their biggest?
I don't want to speak for Zeph and say that I know exactly what their biggest concern is about it. I think doing it in an intentional way that is not like overwhelming the system is really important, and that's what we're trying to stay in tune to. Is you all know how what a heavy lift it's been with your provider network in the last couple of years. So we just want the conversation to be in a place where they can receive it and they can have their staff available, so that we know that like decisions are not being made in any way like without them. If we have to wait on a meeting until we have the right people in the room, then we'll wait.
Yeah, I love the idea about, measuring outcomes, but in so many other situations, I've seen it done wrong.
Mhm.
And, providers are allowed to provide their own narrative in terms of their outcome data, and it isn't truthful.
Mm-hmm.
And I would really like to see built into this program something to ensure that the actual clinicians are incentivized too,
Mhm.
not just the organizations.
Yeah.
Because that's something I'm really passionate about, is making sure that we're taking care of the actual clinicians.
Uh-huh.
Mm-hmm.
And,
I think that was the biggest thing that was the biggest thing on this table, was about the clinician, because that is the actual work. That is actually what happens, and without them, what happens then?
Yeah.
I don't want
Everything
to.
else is people pushing.
If we're just incentivizing and we're giving more money to get good numbers and improve care, wonderful. But where is that money going? Is it going into the pockets of the people who already make $100K, $200K a year? Or is it going to the pockets of the people who are like busting their butts and trying to really help, and they can't get ahead in the world? So I really want to see something that goes into programs.
Yeah.
Great ideas.
I mean, actually, both sides of the coin matter, because you want to hit administration as well, so they're not overloading you, right?
Mm-hmm.
They're giving you the opportunity to provide really quality service.
Well, the long-term narrative of all of this is everybody cares.
Right. Right.
And imagine what our community would look like if all of our providers across the board had a culture of everybody cares.
Mm-hmm.
Mm-hmm.
As much as we do in this room. Think about that. I mean, wow.
Well, you
Talk about a shift in
yeah.
our community.
You had your hand up.
Yeah, so I was just curious, have you guys, do you guys have any consumer reps in these discussions, or done
I
like a
love that
consumer forum or
question.
something? I mean,
Thank you.
it would be, I think, really beneficial to have their input on what outcomes they want measured, what's
Yeah.
important to them,
Mhm.
that kind of thing.
Yeah, there's two groups, I guess, within what you're describing that we are always advocating for in these meetings. People who are working for the provider, who have lived experience, so peer supports and recovery coaches, but also users of the system.
Right.
Okay, we would not hold a focus group for drivers of Ford F10 pickups if we had nobody who owned a Ford F10 pickup in the group, right? It wouldn't make a lot of sense. And it's also not fruitful or not helpful to bring them in after decisions have been made to kind of bless something or kind of cut the ribbon when we needed them for the process. So yes, that is encouraged and they are being brought into these conversations.
That's great.
Are there any best practices about whether, and if so, how data are made public about outcomes and about satisfaction?
Best practices, I guess I would say that starts with a conversation to say, what do we have to lose by publicly reporting this data? And within that definition, does that mean what do we have to hide? So there are communities who are incredibly transparent with their data. Sometimes it's at the expectation of the payer. You see this in places like Arizona. You can find a very nice dashboard that says, here's the number of people who are served. Here's the timeliness to access. So I don't know that there's a best practice, but I think the more transparent you can be as a result of a collaborative conversation. I mean, these are taxpayer dollars that are paying for these services. So shouldn't they be privy to know how well they're working?
Yes.
And there's, it's happening. Medicare, publishes hospital data.
Yes. Mm-hmm.
Yeah, I think it would be really cool on our dashboard to be able to say X amount of lives saved, X amount of people, access to services, all of this. And I know you guys probably heard me say this, ultimately who we work for is community. And for us to not go back and tell them this is who we are and this is what we're doing is like, who would hire somebody and not expect that employee not to come back and report back to them? Who? Not a one of us. If we paid for a service, we'd want to report, right? When we do our taxes, we want that CPA or that accountant to give us our tax report back, right?
Yeah.
I mean, I think it's incredible. It was one of the things when you mentioned the dashboard on the website, I'm like, writing that down because we can figure out what should be on that dashboard, but I love the idea of reporting back to the community. This is what we're doing because we're doing incredible things.
Yes, and for those of you who've been in the system for a long time, we can't rely on a narrative or an anecdote anymore to prove that the services are working.
No.
We have to show data. We have to show that people are being served well. A lot of the questions that y'all have brought up today kind of speak to how challenging and what a heavy lift this can be. And I agree with you. I'm not here to tell you that this is easy and like it's going to be 1, 2, 3, bang, bang, bang. But it's also very important. It's very important to get right, and it's going to continue to reflect the way that the board is kind of leading the way in the state of Ohio when it comes to your crisis services. To not just say we've got to have these services, but we have to have an assurance that they're working.
Yeah.
But that doesn't come at the expense of your relationship with your provider. No, quite the contrary. It's a very collaborative relationship with your provider that allows you to achieve these outcomes. I was at the National Council for Mental Wellbeing's conference last week, 3,500 people, biggest behavioral health conference in the country. And the most inspiring stories that I hear at those conferences are when a payer and a provider go up to the microphone together and they say, we did something together. We made it better because it was the right thing to do. We trusted one another. If we weren't sure about something, we were proactive about it. We didn't fall back to distrust or skepticism. And we said, we're going to bring a level of faith into these relationships that we're doing the right thing and we're doing it together. So I think through this process, you will come, the people who are involved will come on the outside, come on the other side of it, I should say, with a higher degree of trust that the crisis services are working, with a higher degree of trust in one another, and with an improved service continuum.
Well, if you think about, we serve 22,000 people, right, Scott? In 2021. if you multiply that out by the size of the families and extended families and all that get, all the individuals that would, one individual is challenged with mental health, and you multiply that out, we're talking about, 150,000 people that we directly affect. So this is just really exciting, and thank you for taking the time and addressing all of our questions. And I just want to encourage everyone to ask questions, even if you already know the answer, if you think someone else might. You saw me how many times I stopped all the acronyms and said, now what does that mean? Because I want to make sure that everybody is comfortable and understands what's going on.
Well,
Thank you.
I'll give my last voice. I like you said something in the very beginning to me, what I think the definition, the value was, that is the social determinants of health for individuals trying to recover.
Mm-hmm.
That's what I see. People trying to recover, the value is what are their social determinants of health. And having them included with saying, hey, okay, this is what we need, and looking at that, and so we're gauging that data and metrics based on what they're saying that's being needed, and then having a way to gauge that, I think, is important. So having peer support as that added incentive to bring that conversation out into the community, because not a lot of people in the community know what peer support is and what its real function and role is supposed to be. This takes it off the table from sitting behind the desk and answering the phone and actually putting them in the position in the community.
Thank you.
I just have one more thing to say.
Sure.
This kind of goes back to what a couple different people said, but when it comes to your clinicians, if we're coming from a place of saying that we care, and then we're coming from a place that we're saying that we're going to pay for a level of service, then we have to show those clinicians that we care about them and their well-being and taking care of them and make sure that they're paid well, or at least incentivizing them, because the better we take care of them, the better our providers are taking care of, especially those, those curb level clinicians, the better service they're going to provide for people coming to them. Then I feel like there'll be less turnover, and then there won't be as many gaps. There won't be as much crisis, because people who are in crisis, they need somebody. But if you're down 6 clinicians because somebody else is paying more over here, because right now, because we see at our agencies, people are jumping ship all over looking for the next bigger, better, or just making more money because there's need everywhere. So how, looking at this system, how are we going to keep these clinicians here to serve the people who are in crisis and not them jumping ship to go over here because they pay $2 more an hour and, give them 3 more PTO days? How do we incentivize, or what are we going to do to help support them to keep this, intact? Because they're the ones doing all the work. So how do we do that?
Well, what do you say we give Travis a round? Thank you, Travis. This is not the last time you'll be hearing from Travis, as you all know.
Yeah.
We appreciate the work he does, and I would just echo the words he said about Subset. We're doing incredible work. Yep.
And I felt like I need to upgrade.
That's it, folks. That's all right. You told me.